We have arrived at our final general session of HSG 2024. I can't believe it. You can applaud. That's all right. I'm for it. Go ahead. That's right. This session is poster highlights, and we have two presenters to discuss the unique structural properties of how sites interact with an country, continent, and at the site level. This session will be moderated by our CEO, our head, I'm going to call him our head dude. What do you think, Dr. Clausen? Please stick around immediately after this session for some closing remarks from Dr. Clausen. And here he is. Take it away.
Great. So one of the big questions we raised at the very beginning of this meeting was how we relate to each other in terms of networks, and this is a really great opportunity for us to hear about some of the exciting work going on in Australia, and also a lot of us in the United States don't know how the HDN is set up, so it's be a great opportunity for us to hear about that. So we'll start off with, I think it's you, right? Yeah. So Julie Stout has been working tirelessly on developing integrated networks in Australia and has done some really interesting things. So let's hear about this one.
Hi, everybody. I'm delighted to have a few minutes to tell you about Huntington's disease in Australia. What is that? Oh, the slides. Okay. I've got my disclosures here. And so first let me tell you about Huntington's disease in Australia. About 5 years ago, I was fortunate enough to get a research grant. It's something like a K award that you have here, which is funding to an investigator. And from that grant, I've been able to do a lot of work really looking at the scope of HD work, both clinical and research work across the country, and develop some new initiatives which we've been progressing. But first, what I want to do is tell you a little bit about the context of doing HD work in Australia. Then I want to talk about how much HD there is in Australia, how care works, what some of the unique features of that are, and then I want to talk about some of the challenges of getting treatments approved into patients. So first of all, this is really a really informative slide because you can see if you look around at the light green areas, that's where the population of Australia is. And when you see the dark green, that's what we call our HD desert. But it's the desert of everything, not just HD. So not very many people at all live in those dark green areas, like less than 1 per square mile. We have a population of about 25 million, a geographic size of about 3 million square miles, which is very similar to the geographic size of the United States. We have a good minimum wage across Australia. It's 24 Australian dollars, and that equates to the best minimum wage you have in the best top 7 states in the United States. We have low wealth inequality, and I can tell you the prevalence of HD is unknown because we've never had a countrywide study of prevalence of HD. We are working on one now. But we think it's probably between 2,200 and 3,000 people, and we think it's at least 8.4, 8.5 per 100,000, probably more. Australia is interestingly different from the United States because the Australian government believes that all essential healthcare services should be available to all residents. And so we have a Medicare, the system is called Medicare, so it's a federally funded system. It funds GPs, specialists, allied health, and so on. We also have private insurance that's available, and that insurance feeds into the healthcare system because it brings additional money into the system that really props up the federally funded component of healthcare. So just to give you an idea of what that costs, in a family of 4, like my family, I have adult children. They'll be covered until they're at the age of 31. And we pay about the equivalent of US dollars, about $450 a month. What that does is it expands the availability of health care into non-essential things like, we can get a lot of physical therapy, go to Pilates, have a massage, you can have naturopathy, all sorts of things. But in addition to that, it gives you some augmented services that are federally funded, like private rooms in the hospital and things like that. So that makes a big difference in terms of everyone being covered. We also have a unique feature, which is amazing. It's called the National Disability Insurance Scheme. About 1,200 people so far with HD are on this scheme. What it is funding for Australians with disabilities to support their access to services and assistive technology. You can get support directly for your HD care, like help at home and things like that. You can also have, there's also a component that's called the capacity building component, which allows people to engage in their hobbies and get out into the world. So, to get out to a football game or, pursue their educational goals and things like that, you can use your disability insurance to fund that as well. So people have to apply. It's hard to get. It takes a couple rounds usually, and then you get an allocation of a support package. You can use that package to pay for services that are external. You can also pay your family members for the care that they provide. And you can imagine this has major economic impact in the families where they have this support. By the way, that's just been going since 2013 or 2014. We have relatively few HD specialist sites in Australia. They're shown in those black dots that you can see around the map. That's mainly where all the population is. I also have New Zealand on this slide because it was there for something else. But that is another interesting story itself. And some of the specialist sites in Australia also provide some of that disability support and get paid through the NDIS. So that helps with their bottom line and expands, in the clinics that are doing it, expands what they can also provide. And to give you a bit of perspective, we have fewer than 10 real HD clinician specialists who are neurology trained, movement disorders trained, although there are a lot of allied health and other medical personnel that are also trained in HD. We have community advocacy organizations. We have one overreaching organization, Huntington's Australia, except for the fact that the state I live in, they've elected not to participate in that, so we also have Huntington's Victoria. I'm not being snarky about it. We also have, some interesting models of care that go across the disease spectrum. So the federal funding funnels into clinics, whether it's HD or whatever other kind of GP clinic or whatever it is. Just as an example, we have a model called the Statewide Progressive Neurological Disorders Service at the clinic that I'm associated with, which is the Calvary Healthcare Bethlehem Hospital, which is in Melbourne. Interesting model that we have there. It's unique even in Australia, but I think it's really worth mentioning, which is we have a decentralized HD clinician specialist model. So when patients call into the clinic, they get triaged by an expert nurse, and they don't necessarily see a medical doctor first. They don't necessarily see a neurologist or a psychiatrist. It could be a psychologist or a physical therapist or OT or whatever. But those people are the HD clinician specialists. They have really a deep training internally within that system. And there's an interdisciplinary, very close working interdisciplinary team. People don't pay for those sessions. They can come in, as long as they can get into the clinic. Our clinic has a few months waiting list, but if somebody's in a crisis, we can get them in right away. And NDIS, as I said, can help to support that as well. In terms of people who get genetic testing, who don't necessarily need a full clinical engagement and perhaps don't want to be associated with a clinical setting, we are working toward a model where we offer repeating video conference sessions with HD information, information on the search for treatments, stuff on lifestyle and wellness and social connectedness. And we've been piloting some of these elements already, but starting toward the end of the year and then going into next year, we're going to start this repeating program. So this will help us keep track of people soon after they get genetic testing. In terms of research and clinical trials, these are just showing enroll sites in red there. So there are actually 4. It looks like 3, but there are 2 in Melbourne. And this is something we hope to expand in the near future. There are a number of researchers from Australia that you would have heard of, and there are a range of interesting projects, but not that many because we're a very small country with a small research community. The final thing that I want to talk about is just how getting drugs approved works and how the clinical trial setting is there. So we have, just like the FDA, we have the Therapeutic Goods Administration. As you can imagine, it's much smaller. And then we have another government organization, which is the Pharmaceutical Benefit Scheme. And so that scheme is how you get drugs paid for. So if you get a drug approved by the TGA, then you go to the PBS, you apply to the PBAC, which is the committee that then evaluates using health technology assessment. They evaluate the impact on burden of disease and that sort of thing in order to determine the kind of cost benefit and decide what to provide subsidies for. We only have one drug approved for HD in Australia, which is tetrabenazine. We don't have deutetrabenazine approved yet. We don't have anything else. So that's an area, and we're not really even that ready to get drugs approved rapidly and out to patients. We have a favorable clinical trial setting from the point of view of getting trials approved to be in Australia. You have to have a local sponsor. There's a few ways to do it. You can do it through just basically your local IRB, or you can do it through the Therapeutic Goods Administration. It has to be approved, they have to be notified at least that you're doing it. There's also another support agency, which is called Medicines Australia, and they are funded by the Australian government, but they represent the research-based pharmaceutical industry in Australia, and they facilitate clinical trials with things like templates for clinical trial research agreements and so on. We also have multi-site approval through the ethics committees. And this is my last slide, which is that we also recently have established an Australian-New Zealand clinical trial network. Most of our sites are involved with the HSG, but we have some local issues that we need to address in the local setting. That means that we do need to organize ourselves as well. So we hope that we can do that in a complementary way with HSG. But this is going to help us prepare for the advent of new therapies for HD, hopefully attract more trials into the region. Many trials have come to Australia in recent years, but they often just pick one or two or maybe 3 sites. We'd like to see a broader availability of clinical trials both in Australia and New Zealand, and we'll be facilitating that. We'll have a one-stop shop for contract negotiations. This is what the sites want to kind of make things easier for them as well, and that trial is well and truly underway. So we're not really ready to rapidly get drugs approved or get them onto the PBS. There's a lot of work to do. We don't even have a prevalence study to inform the cost of illness and things like that. But there is a lot of interest in developing these things, and the setting is really quite different. And I think even though we have a small population, it's a relatively untapped population for clinical trials, and we hope that we'll have more opportunity to get the trials there because we know that that's going to underpin us getting treatments to patients as soon as possible and getting them funded within the system. So that's all I needed to say. That's a picture of that desert in the middle. It's a beautiful place, and I want to thank Dan and the group for giving me the opportunity to tell you about what's going on in Australia. Thanks.
Any questions? Or there's one question from Danielle over there.
Hiya.
Sorry, super quick. I
Sure.
met Melanie Clark, and she's
Yeah.
amazing. I was just wondering what are kind of the steps towards helping the Aboriginal population with HD?
Yeah, so there was something about that on there, but I skipped through it really quickly. Melanie Clark is a PhD student in Western Australia who is going out into remote communities, because Aboriginal people, are mainly living in the cities like the rest of us, but there are still remote communities where they live, and there's also these separate healthcare organizations called Aboriginal Controlled health care organizations. They can, have their own clinics, and they can do them the way they want, and it is federally funded, but it allows them to have a more flexible model. Melanie is going out and has identified she thinks of around 50 families with HD. Families is kind of interesting in those areas because everybody's auntie and uncle, and kids sometimes don't live with their parents. It's a very flexible and broad concept of what a family is. And one of the things that Melanie is really interested in is the kind of disparities in in healthcare that's available to people with Huntington's disease who are living in these remote communities. So we're in the early stages there. You know, a lot of our measures and so on, the outcome measures are really not, you know, very appropriate for those communities. They just, you know, really are living a different lifestyle than the people in the cities. So she's really working on really how to approach things with those communities. What do they want? They're oftentimes quite suspicious of people kind of coming in and offering them things because it has had bad outcomes for them. We've had a eugenics movement like there has been in this country that, you know, ended only a few decades ago. So there's a lot of work now to start thinking about how to provide services in a way that's sensitive to what people want who are in those communities that are quite different than the ones we have in the cities. So thanks for the question. I'm glad I had a chance to say something about that. Thank
you so much.
Yeah.
Jenny, can come tell us about the EHDN on this side of the pond.
Hi everyone, thanks very much for inviting me to talk about EHDN. Let me just see if I can figure this out. So no disclaimers, I'm employed by EHDN. So EHDN has an overarching mission statement, which is to advance research, conduct clinical trials, and improve care for people affected by Huntington's disease. Wanted to give you just an overview of the key information. There's a lot of information in these slides, so I will skip quite quickly through some of them. But please come up to me afterwards and ask me any questions you like. So EHDN, founded in 2004, it's CHDI funded. There are more than 3,500 members across Europe and beyond. Members in Europe are regular members. Members outside of Europe are associate members. There are several HSG members who are associate members of EHDN and also involved in some of the EHDN working group activities. There's a network of 156 expert HD clinical sites in 18 countries in Europe. EHDN is governed by an elected executive committee who are advised by a slated and elected scientific and bioethics advisory committee. There are central coordination staff who support legal, administrative, and science management operations. And we have a team of language area coordinators, also known as LANCOs. They're called language area coordinators because they speak the native language in a particular region. So our language area coordinator for France also covers the French-speaking part of Belgium, for example. They support sites with clinical research activities, including Enroll. Currently 52 staff in EHDN. You'll see that the proportion of staff who are solely EHDN is 25%. The reason for this is the EHDN has subtly shifted from the days where we ran the European registry study. Now many of the EHDN staff almost solely work on Enroll HD. A lot of the team members have been around since the registry days, and the operational and study management skills have transitioned across to the Enroll HD study. So the first mission statement, advancing research. There is a clear EHDN scientific strategy. Suffice to say that this strategy is a strategy document. It's a plan that is periodically reviewed and updated to make sure it takes into account the changing landscape, opportunities, and needs. That's currently on revision 2. So the key activities for advancing research are guided by this EHDN scientific strategy. So promoting collaboration between researchers, healthcare professionals, and HD families is very important. That's clinicians and basic scientists as well. There are biannual plenary meetings solely dedicated to HD. EHDN conducted the registry study and contributes to the Enroll HD study. So there's that crucial clinical data and biosamples. The registry legacy database is still available for researchers. There's a grants and collaborations manager who can support researchers in identifying funding opportunities and collaborations. And the Leslie Jones Seed Programme I'll talk a little bit more about, as I will the think tank working groups and task forces who address key research questions and promote collaboration. The Leslie Jones Seed Fund Programme has 2 calls per year, offers funding of up to €50,000 to fast-track pilot studies that are required to apply for larger grants, or maybe to estimate statistical power that's needed to plan larger studies. Applications for seed funding are particularly encouraged from the EHDM working groups. And you can see, probably very small on the table on the right-hand side, examples of how projects that were seed funded have then led to awards of considerably more money for those projects. The think tank. So the think tank feeds directly into the executive committee, works alongside the SBAC and central coordination. So the role of the think tank is to oversee and support the working groups, to help identify synergies between groups, connect members, and promote collaboration. The think tank is also there to receive suggestions from EHDM membership. If someone has an idea about a topic that they think should be investigated further, they can suggest that to the think tank. The think tank can also identify topics they think are critical for research, and there's the potential then that a new working group or task force may be convened. The other remit of the think tank, of course, is to ensure that the working group and task force activities that are ongoing are aligned with the most recent scientific strategy. So working groups and task forces, I won't go into detail in any of these, but you'll see that there are quite a lot of overlap with some of the HSG working groups, so it would be good to get more collaboration between these groups. Just some examples: output from the groups, opinion from the imaging working group, physiotherapy working group guidelines that have been translated into multiple languages in Europe, and guidance from the incidental findings task force. Other key EHDN initiatives that are ongoing at the moment is the Regulatory Science Initiative. This is to facilitate clinical trials in Europe by interacting with the European Medicines Agency. The first project is the process of the EMA qualification of the HDISS staging system. This group's led by Pavlina Konstantinova. And another ongoing initiative that's just kicked off is a brain bank for early stage post-mortem brains, just to make sure that it can maximise the opportunities to be able to obtain very early stage brains, because there's such a small number of cases every year. The other initiative, I'm mentioning this because a huge amount of work has gone into this so far, and it's very close to submission. This is an initiative led by Flav Georgini, and it's an application to the Marie Curie Doctoral Network, Strive HD. It's a bench-to-bedside training network, and if awarded, it will cover 15 PhD studentships, 13 PIs, and in 8 countries. There are 3 work packages, and we expect that Part A of the submission will be in at the end of November. Facilitating clinical trials and studies. So EHDN endorses trials and studies. A protocol is reviewed by the SBAC, which can include an ethics advisor and an external expert as appropriate. And then the SBAC make a recommendation to the executive committee about whether a trial should be endorsed. So there are 4 criteria that a trial should meet, based on a solid rationale, not expose participants to substantial or unacceptable risks. It should be appropriate and comprehensive and have a feasible plan, and the demands on participants, families and resources should be acceptable. With endorsement, if a sponsor chooses this, the statement of endorsement can be made public. Information about the study could be put on the EHDN website and promoted in the newsletter. And with EHDN permission, sponsors may also use the statement of endorsement to support ethics and regulatory submissions. Just a snapshot of recent and currently endorsed trials. EHDN endorses trials, but also clinical studies. Of course, Enroll HD is one of the endorsed studies and has significant operational support from EHDN Central Coordination and the LANCO team with study management and monitoring in Europe. Improving care. The fellowship programme is one of these key activities that's a joint joint programme with the Movement Disorders Society. It's a fellowship programme for HD professionals from underserved countries, so they can apply for placement at an experienced HD clinic in Europe. We have PIs who volunteer themselves as hosts, and then fellows apply and then are matched with the most appropriate host. This year there was a really high interest in the scheme, 64 applicants, 55 of whom were eligible and will go on to be placed in a host clinic. We had anecdotal feedback that this was very highly thought of, but there was a fellowship impact project run this year, and the results confirmed that it had been really helpful. A significant proportion of the fellows continued and worked in the HD field. They felt that there were substantial improvements to their clinical practice back in their home country, and they reported extensive opportunities for collaboration with hosts and ongoing mentorship opportunities. Education, there's a series of online and on-site education courses, again, co-sponsored by MDS and EHDN. There's been recently an HD workshop in Armenia, which built on links between a host and a fellow from the fellowship programme. So the host went to Armenia to visit the fellows clinic and run an HD workshop. There are more sessions with MDS PAN planned. And working groups, there's been a paediatric working group podcast recently, and the physiotherapy working group has produced clinical recommendations to guide physical therapy practice. That has also been translated into multiple languages. Outreach, collaboration and network. We have a dedicated communications group now who's responsible for all the regular communications. So we have a newsletter that comes out 3 times a year. I think the latest edition just came out this week. You can sign up on the EHDN website to receive that newsletter by mail. There's the EHDN website, information on everything that I've spoken about today. We have now dedicated social media channels. The communications group has also started to host virtual platform meetings. So we have webinars with invited panel discussions with EHDN members, can talk about emerging clinical trial results. There's been a webinar for the think tank and working groups to collaborate, and it's hoped that there's going to be more regular webinars in future. Some of you may have been at the meeting. You'll see just from a quick snapshot of the agenda that it's fairly similar to this meeting. What's nice is that we have a full day dedicated to working group meetings before the plenary meeting, so people get to meet and discuss ideas in person. And if you want to see any of the presentations for that meeting, they're available on YouTube. And I'll leave you with this. So please keep in touch with the HDN. It'd be great to start to build more relationships with the HSG, identify where we're working on it, overlapping areas, and to join forces. And just to flag, our next conference is in Krakow in 2026. Okay.